Colleagues, today we are especially delighted to welcome the Minister for Health and Aged Care in the Australian Government, the Honourable Mark Butler, to open this event and to thank him for taking the time to do so in a very busy period and, of course, with the National Health Portfolio itself. Can I also acknowledge and be very clear about our own relationship in terms of both health and welfare and the future with the First Nations ancestors, elders, and families of the Wurundjeri of the Wurrung people. We're very, very committed to this as a university. I know the government is as well, but it is very much the case that this guides our research, our collaboration, very much our discoveries and our research on the public interest as well. Now, Minister Butler's presence today acknowledges the important work undertaken by the Australian Health Policy Collaboration and Victoria University's Health Policy team over more than a decade. It's a 10-year-long process. The contribution that has been made to contemporary health policy priorities is immense. And as you will have seen from media coverage today, very much recognized as well. Minister Butler has been Minister for Health and Aged Care since June 2020 and is leading an extensive policy program to strengthen equitable access to healthcare for all. We could not be more supportive of that agenda. Today's publication, Getting Australia's Health on Track and Australia's Health Tracker 2024, are focused on the broader goal, though, that the Minister is also committed to and is embracing, that of, quote, reducing the barriers to good health and well-being for people living in socioeconomically disadvantaged communities throughout our nation. Can I ask you all to join me in welcoming Minister Butler to say a few words? Thank you so much, Minister.
Well, good afternoon, everyone. Before I begin, I'd like to acknowledge the traditional custodians of the land on which I'm recording this message, the Ngunnawal and the Ngambri peoples. I pay my respects to their elders past and present and to First Nations people who are participating in the webinar today. Thank you, Professor Coulter and the Australian Health Policy Collaboration for leading the work on these reports and for inviting me to take part in your launch. I'd also like to acknowledge everyone who's worked on the reports, including Dr. Erin Lawler, Tracy Johnson and Professor Tim Gill. And of course, your guest speaker, Dr. Mukesh Haikerwal, a passionate advocate over many years for more accessible and affordable healthcare, areas I'm also passionate about, as is our government. When you look around the world, our health system rates very highly in terms of equity of access and health outcomes. In fact, the Commonwealth Fund report released just last month ranks us as the top performing health system in the world, overall and in terms of health equity and outcomes. Importantly, number one for health equity, and Medicare is right at the core of that, but also number one for healthcare outcomes. And that's something that should be celebrated, something we should be proud of, particularly in the year of the 40th anniversary of Medicare. But we do know it's a healthcare system that's under real pressure. As a population, we're getting older and we're getting sicker. There's more complex chronic disease, but also more mental illness in the community that's putting pressure on primary care as well as our hospital systems. My goal is to make us number one across all parameters, and the reports released today make it clear that we can and must do better for many of our people. They show that socioeconomic status continues to have a major impact on people's health, and increasingly related to the risks of chronic and preventable conditions. Almost 1 in 3 Australians living in our most disadvantaged communities have 2 or more chronic health conditions, compared to just 1 in 8 of those living in the most advantaged areas. Disadvantaged communities also have the highest rates of suicide. I know your collaboration is seeking to achieve a greater effort on preventative health. We've already taken major steps, but there is still work to do. First, we've made primary health care affordable and accessible to all. Our government has made the largest investment in bulk billing in Medicare's 40-year history. Data shows there's been almost 5 million additional bulk billed visits since our government tripled the bulk billing incentive last November. We're also providing fully bulk billed treatment at both Medicare urgent care clinics and Medicare mental health centres. We've also made PBS medicines cheaper so people can afford to purchase the medicines that they need. This has delivered hundreds of millions of dollars in savings to patients at the pharmacy through those cheaper medicines policies. It's also meant that thousands of Australians living with high cholesterol, kidney disease and ovarian cancer, to name a few, will now have more treatment choices for just over $30. At the same time, we're doing the groundwork to embed preventative health in primary care. My Medicare voluntary patient registration is a year old now. This model was created to support the relationship between patients, their general practice and primary care teams. We've also targeted specific preventative health issues with increased funding, including vaccines, anti-smoking and anti-vaping measures, sexually transmitted infections, as well as lowering the age for bowel cancer screening. We're working with communities to ensure health promotion messages are culturally appropriate and understood, and we're developing innovative measures to empower disadvantaged Australians to protect their health in their everyday lives, including a national health literacy strategy, a national consumer engagement strategy for health and wellbeing, and a feasibility study into social prescribing. The Australian Health Policy Collaboration is undertaking this feasibility study, which is also expected to be completed in coming months. Another example of your great contributions in this area. We need to continue to reduce health inequity and give everyone an equal chance at achieving the best possible health outcomes. And with your support, we can continue to work towards this. Thank you all very much.
Minister, we could not be more delighted with the support, the leadership, and the incredible vision that your government has enumerated. It is also the case that the direction of this very project, with the multiple team members, but led so ably by Professor Rosemary Calder, has been just terrific and very, very influential. I know that Rosemary was quoted in the media today as saying that it's hiding in plain sight that we have communities that have poor health conditions, higher needs, and earlier deaths. The places where they live, though, have significant socioeconomic challenges, as you pointed out. And Minister, as you said, we do have a world-leading healthcare and healthcare outcomes nationally. But as you've emphasized, many in Australia do not share that well-being and have poor health based on where they live and their opportunities. So therefore, universal provision is one thing, but it's not the same as equitable opportunities for good health and well-being. And that's what this very important tracking study addresses. We could not be more proud, and on behalf of our council, to say that Victoria University and the Australian Health Policy Collaboration have worked together to improve those policies, the ones that you've just enumerated, for more than a decade. And for the past 6 years, that work has been partially supported by a grant from the Department of Health and Aged Care. On behalf of the University of Victoria University, I thank the Minister and the department for the support, and thank all of those who contributed to the work of AHPC over that time. It's been legendary, and thank you. The AHPC is an excellent example of sustained professional leadership, collaboration, of research-led outcomes, building consensus between diverse experts and organizations to really strengthen the use of evidence in policy making. It is a real hope and a fervent hope of all of us, and my personal hope, that today's event will amplify the value of that work, of that very crucial work, and Minister, be seen to influence and assist the ongoing work of your ministry, the Australian government, the Department of Health and Aged Care, and all relevant national, state, territory, and local government authorities. Minister, I cannot thank you enough on behalf of all of us for joining us here today. I'll now hand over to Professor Rosemary Calder, whom I mentioned earlier, to speak about today's publications. And again, we are just delighted to see them getting Australia's health on track and Australia's Health Tracker 2024. Rosemary, congratulations from me and all of us.
Thank you, Vice-Chancellor. Good afternoon, everyone. As you've heard, I'm Rosemary Calder. I'm a Professor of Health Policy at Victoria University, and I've led the Australian Health Policy Collaboration Program since its inception. I'm the MC for this webinar today, and I hope you'll excuse my somewhat croaky throat. My first task is to draw your attention to some of the webinar arrangements for today that you can see on this slide. The webinar is being recorded. We are delighted to have such a large participant audience, and to manage that, your questions or comments to the panel will need to be made through the Q&A box on the base of your screen. These will be recorded also, and we will publish the recording and transcript of the webinar on our VU website. This This slide shows you how to upvote questions in the Q&A inbox. You'll be able to view questions as they are posted on your screen, and upvoting helps to highlight those questions that a number of people want to have discussed. And finally, using Speaker View is usually better for a webinar. As you've heard, today's webinar is launching 2 reports, Australia's Health Tracker 2024 and a 3rd volume of Getting Australia's Health on Track. These 2 reports and their predecessor publications have been undertaken through the Australian Health Policy Collaboration, which is an informal network that came together in 2014, soon after the Health Policy Group at Victoria University was established. The AHPC, as it is known, has been supported by the university and for the past 6 years has been partially supported through a grant from the Australian Government Department of Health and Aged Care, and we thank our colleagues in the department for their support through this work. The AHPC's purpose has been, as you've heard, to establish expert consensus positions on evidence-based policy options that will most effectively reduce preventable chronic diseases in our population. Let me talk now about our key publications. Australia's Health Tracker, another volume of which is being launched today, is a signature publication of the AHPC. It's a report card that charts progress in Australia towards improvements in key risk factors for poor health and preventable chronic diseases. Getting Australia's Health on Track is a compendium of feasible and affordable policy proposals that will achieve effective improvements in those risk factors. Getting Australia's Health on Track reports are written to be easy to understand, clear and precise about what will work and how, and are for those who may not be experts, but who are key decision makers and advisors in the Australian policy environment. AHPC publications include a series of policy issues and implementation papers on specific ways in which physical and mental health and healthcare can be improved through policy or system improvements. All of these publications are resources for wide use. They are for you and others to use in your work. Today's new reports are focused on the extent to which the socioeconomic status of local areas in Australia is a strong indicator of the extent to which people in those areas are likely or not to have good health and well-being. Where you live, as the Vice-Chancellor has said, does indeed influence your likelihood of lifelong good health and your risk of early death. Australia's Health Tracker 2024, Chronic Conditions by Socioeconomic Status, spotlights the disparities in health across our country. With 40% of people who live in Australia's most disadvantaged communities experience significant and increasing rates of preventable health conditions. Getting Australia's Health presents a suite of implementable policy proposals aimed at improving those health outcomes in communities experiencing high levels of socioeconomic disadvantage. I'm now going to hand over to Stella McNamara of the VU Health Policy Team to discuss the data presented in Australia's Health Tracker 2024.
Hello, I'm Stella McNamara, the Senior Policy Associate here at the AHPC. And as Rosemary said, today we're launching the latest Australia's Health Tracker report card. Australia's Health Tracker, Chronic Conditions by Socioeconomic Status. It demonstrates how socioeconomic status affects health outcomes. Socioeconomic status is the measure of people's access to material and social resources. This tracker shows us that those with limited resources are at greater risk of both experiencing chronic health conditions and dying early from those conditions. Before I get into a quick rundown, I just want to thank Professor John Glover and his team at FIDO for their work in supplying the data. On the screen at the moment, you can see we have rates of premature deaths and suicide. On the top left in the bar graph, you can see the premature mortality rate divided into socioeconomic quintiles. Left to right show the bars show least to most disadvantaged. So the bars on the left are the 20% of communities with the least disadvantage, and the bars on the right are the 20% of communities with the most disadvantage. The darker blue is the most recent data. The light blue represents the comparison year. For both bar graphs on the screen, you can see that the most disadvantaged communities have higher rates of premature deaths and suicides. I'm now going to talk a bit about comparative data over time. So it's important to be aware that the comparison year and the most recent year of the data in this tracker is not consistent. So the line graph on the right compares just the least disadvantaged quintile in pink to the most disadvantaged quintile in purple across the 2 time points to highlight the gap between them. And while both are decreasing in this instance, there is a greater decrease in the least disadvantaged areas, increasing that gap. And we see a very similar trend in chronic disease prevalence as well. On the next screen, we've got the chronic disease prevalence of cancer, heart, stroke and vascular disease, and diabetes. I won't go through them all, but you can see the same trend is emerging. In general, the more disadvantaged, the higher the prevalence of the individual chronic disease. And over time, the gap between the most and least disadvantaged quintiles is increasing. And that's regardless of whether it's increasing or decreasing in prevalence. The cancer prevalence is particularly stark. In the initial time point, there was actually a relatively similar prevalence across the quintiles. However, the latest data shows a large gap. On the next slide, we have COPD and mental illness. With COPD, chronic obstructive pulmonary disease, the same trend applies, but in this case, you can see that only the most disadvantaged quintile has increasing prevalence, while all of the quintiles are decreasing, and it's quite a stark gap. Now, mental illness is the one that bucks the trend, and you can see that there was a bigger increase in the least disadvantaged areas between the 2 time points. That is, the gap between the most and least disadvantaged quintiles and communities is getting smaller. Setting aside the reporting on mental illness, what most of this data show is that essentially health disparities within the Australian population are persistent and widening. The gap in prevalence between those in the most disadvantaged socioeconomic quintiles compared to the least disadvantaged quintiles is growing for almost all the chronic conditions highlighted in the tracker. And this is despite policy efforts to date that address increasing rates of chronic disease. And that's not to say that policy attempts are futile. They can and do work, but one-size-fits-all approach is not effective everywhere. So tailoring preventive health initiatives and looking upstream to the wider determinants of health is essential. And this is where getting Australia's health on track fits in. So on that note, I will hand back to Rosemary.
Thanks, Stella. I'm now going to talk about the process that we've used to develop the report that we're talking about today, Getting Australia's Health on Track 2024. Let me first say, as you can see on this slide on the left, the AHPC first came together through a sector-wide agreement in 2014 to work on developing targets and indicators for preventable chronic diseases in the Australian population. This work was aligned with targets established by the World Health Organization for global reduction in preventable chronic conditions. The AHPC targets and indicators were compiled by leading experts and have been updated in line with the most recent population health data subsequently. These targets and indicators have been the baseline for all of the AHPC work. As you can see from this slide, a consensus-building approach is used for the work undertaken by the AHPC's expert participants. This slide shows you the particular process for Getting Australia's Health on Track 2024. Topic-specific expert working groups are drawn together by nomination and recommendation and work collaboratively to identify problems, consider evidence, including lived and professional experience, and to develop through an iterative process a distilled suite of the policy proposals that are most relevant and most feasible to redress those problems. Previous Getting Australia's Health on Track policy proposals have been focused on improving the rates in specific risk factors that are identified by Australia's Health Tracker report cards. The first 2 volumes of Getting Australia's Health on Track have recommended policy proposals that would encourage and support healthy behaviours and reduce exposure to harmful products and environments. Importantly, the work has emphasised over and over again that socioeconomic status is a key indicator of risk for poor health, and that socioeconomically disadvantaged groups and communities fare much less well than the rest of Australia. These communities have higher levels of risk factors, as you've just seen, with higher rates of chronic conditions, as Australia's Health Tracker emphasises. These communities commonly have higher concentrations of those factors called the wider determinants of health. Factors such as lower income levels among people within the community, lower levels of educational attainment, fewer employment opportunities, lower housing quality and stability, and lower levels of resources and services within the community. Those wider determinants of health underpin the major risk factors for chronic conditions, particularly factors such as high levels of physical inactivity, unhealthy diets, smoking and tobacco use, alcohol consumption, overweight and obesity. For these reasons, the 2024 volume of Getting Australia's Health on Track has focused on why and how socioeconomic disadvantage acts as a barrier to good health and wellbeing within communities, and on what can readily be done to mitigate those impacts. Increasing evidence indicates that place-based approaches tailored to the specific needs and strengths of local communities are the best way to achieve community-level improvements. Indeed, there are now a number of substantial national policy initiatives focused on improving aspects of health and wellbeing in communities. There are also numerous state government level initiatives and local government level initiatives. There are philanthropic and not-for-profit organisations also engaging in place-based work addressing health and wellbeing disparities. There is increasing experience that this multiplicity of initiatives is adding complexity for communities in which these are concentrated, and often adds confusion and can be almost self-defeating. Because policies affecting local communities are multi-layered, with Australian government and state government levels of responsibility, along with those of local governments, we took a systems-level approach to this work. To do so, we established 3 working groups, drawing together experts to consider the problems and needs from the micro-level perspective of local communities, from the meso-level perspective of regional and state-based agencies, organisations and stakeholder groups, and from the perspective of national policies, agencies, organisations and stakeholders, the macro level. The process itself centred on the microsystem, the local community level. The microsystem group, chaired by Dr. Erin Laylaw, met first and identified the range of gaps and barriers that inhibit the capacity of communities to have better health and wellbeing and to benefit from preventive health policies and initiatives. The summary of that meeting was provided to the first meetings of the meso and macro level groups, chaired by Tracy Johnson and Professor Timothy Gill. Their groups considered the identified gaps and barriers from the perspective of their system levels and added to the problems and issues and started to consider options for improvement. The second round of discussions focused on the policy initiatives that would most effectively, on contemporary evidence, redress those gaps and barriers. The third meeting of the microsystem group reviewed and added to the summary outcomes of that round of meetings, and a composite meeting of the 3 working groups confirmed the suite of policy objectives and proposals. The 3 chairs and the project team worked throughout the process to synthesise and refine the information emerging from the meetings, leading to the integrated policy objectives and related policy proposals that this report presents. The next slide shows you the 3 working groups that met through the first half of this year to develop the policy proposals in Getting Australia's Health on Track. This is not a slide for you to speed read. It's a public acknowledgement of the experts who collaborated in this work and assurance to you of the deep experience that has informed this policy compendium. Let me now look at the policy objectives that have emerged through this process. There are 4 policy objectives, and they are the areas where policy attention needs to be focused and where significant change can be achieved in reducing health disparities in disadvantaged communities. For each policy objective, 2 or more policy proposals have been agreed by the working groups. The policy proposals for each objective are those that are considered the most important to achieve immediate improvement at the community level. The policy objectives and individual policy proposals will be discussed by the chairpersons of the working groups in the panel session shortly. My aim now is to introduce the policy objectives to you all briefly. The first is to provide enhanced community capability and capacity through collaboration and place-based community development. Current policies are increasingly recognising the need to support communities to develop the capability and capacity to design and deliver locally relevant approaches to policy problems in ways that work for these communities. Community capacity and community development can help to build social capital and inclusion to mitigate some of the impacts of disadvantage. Community development can empower communities and individuals to implement solutions that are appropriate to their community's particular characteristics and circumstances. Community capacity is achieved through a range of people, organisations and others working with adequate and stable resources to address local needs. The second policy objective is for healthier environments to be achieved through the appropriate use of planning, regulation and legislation. The importance of decisions that affect the health and well-being of the environments in which people grow, live, play, work and age is now well recognised. Inclusion of the potential impacts on health and well-being as core requirements in government planning, legislation and regulation relevant to urban, rural and remote communities would directly facilitate reduction in health inequities and promote healthier outcomes, particularly in disadvantaged communities. The potential for local governments to shape the health and well-being of their communities through their statutory responsibilities, such as community infrastructure and town planning, is also recognised, but only several Australian states require and support their local governments to do so through mandatory health and wellbeing plans. The third objective is investment in tailored preventive health initiatives with and within local communities. Preventive health initiatives can have less benefit in disadvantaged communities. This adds to and exacerbates lower levels of health literacy for individuals and for the communities themselves. The primary health networks and the local health networks that deliver and support health services in all communities are very well positioned to tailor preventive health initiatives for specific communities. It should be a central responsibility of both these critically important organisations to do so collaboratively and effectively. And finally, but not least, achieving equitable access to comprehensive high-quality health care is the fourth policy objective. While Australia, as the Minister has said, is arguably one of the best health systems in the world, access to healthcare and equity in healthcare is lacking for many in our communities. For people without health insurance, longer waiting times for treatment in the public system are common and can contribute to poorer health. For those who have limited resources, the added costs to see a doctor, to have a diagnostic test, or to have allied health treatment can be prohibitive. Access to healthcare for people who live in remote areas is also lacking with lower availability of services. Targeting funding to those for whom financial capacity is a solid barrier to healthcare is consistent with the first aim of Medicare, to make access to healthcare universal and to remove healthcare as a cause of financial distress. As you heard from the Minister, Dr. Mahesh Kalkawal has long been an advocate for the fourth policy objective of equitable access to comprehensive high-quality healthcare. As a long-term general practitioner in a socioeconomically diverse community in Melbourne's West, he's also been a strong advocate for community leadership in health and wellbeing and for health supporting public policies. Dr. Kalkawal will launch Getting Australia's Health on Track 2024. Over to you, Mahesh.
Thank you, Rosemary, and good afternoon. I'd like to acknowledge the traditional owners and custodians of the land in which I'm speaking and those lands where we are conferencing with. Here in the west of Melbourne, it's the Wurundjeri people and other peoples of the Kulin Nation. I'd like to pay my respects to elders past, present and emerging. I'd also like to state all protocols observed, and people who don't understand that means if I haven't recognised you, I mean it, and haven't got around to doing it because I haven't enough time. I'd like to acknowledge the Minister for his kind words and for hinting at my time in advocacy, especially on chronic disease management here in Australia and in the non-communicable diseases space globally. Thank you for inviting me to launch the report, Getting Australia's Health on Track 2024. I've been involved with Rosemary Calder and the team at BU for many years, dare I say it, around a decade. In fact, in November 2017, I was very fortunate to be requested to launch the HPC tracker at the National Press Club in Canberra with Alan Kohler. The common thread through all this, however, is Rosemary Calder, who is a sensational, inspirational driver of thinking and collaboration in this space. That is, getting the evidence to provide policymakers with good information to make wise and sound investment decisions, including evidence-based policy decisions. It's a pleasure to be here with you today and for this opportunity to draw attention to what can easily and readily be done by policymakers to achieve better healthcare for all in Australia. I also salute the teams involved through the VAE process and the experts and collaborators who have tirelessly contributed to this defining piece of work. Having been a commissioner on the National Health and Hospital Reform Commission in 2008-09 with over 100 recommendations, this work is well within our grasp in a timely manner. We have the tools and the guidance to make a difference immediately. I speak as a GP working in Melbourne's West for over 3 decades. I also reflect as the former president of the Australian Medical Association, which in its own way has opened many doors and opportunities to participate widely and for many years in advocacy and policy development. I have been actively engaging and working with local governments, with state governments, and with health ministers and officials in the Australian government to develop and influence health policy and to provide the best opportunity for better health for all in Australia. I have collated and driven what I would call respectful, meaningful engagement. I interacted widely and designed what I coined the 4-cornered round table. That was part of the technology rollout in health, having multiple round tables in one ballroom. We went on to build and drive an agenda with consumers, patients and their carers, with clinicians, with technologists, that was the top topic in question at the time, and decision makers, as well as the policymakers, each on each table, and then collating agreement and directions for further collation of information and drive. This inclusive and proactive method led to uptake of major change in the health sector. As a clinician, I see too many people with health conditions that could have been prevented if patients had access to better information. Early interventions, health support, and reinforced, structured, proactive care pathways can mitigate severe outcomes. Good advice, information, and guidance can prevent deterioration. The man who came to my practice this Sunday with severe chest pain, almost collapsing the car park and in the reception, should have been in an ambulance from home, and with better knowledge and literacy, he would have known how to call one. I've worked with colleagues in my profession and other professions to improve the circumstances of patients whose health is jeopardized by their housing, their lack of resources, and their isolation. Endeavoring to do this often adds frustration to an already heavy workload. Finding special support services can transform lives with guidance and actual face-to-face support from a real person. Once in the hospital system, the outcomes have improved over time with better communications between GPs and the hospital system, and more recently between non-GP out-of-hospital providers. Getting technology, deploying it, and achieving a joined-up system has been like pulling teeth, but we are now light years ahead of where we were when I started this journey in general practice in 1991. Collaboration was when the doors opened, albeit reluctantly. This was in 1992, and reforms then included the funding of divisions of general practice to advocate for better services and interactions and exchange of information. As a community member, I have worked with my colleagues and with public services to untie the tangle of red tape and duplicated effort to get healthcare, support services, and preventative health support to people in my community and others when they need it and where they need it. That, of course, is much more easily said than done. My mentor, Dr. Bill McCubbry, a retired GP in Thornbury, always spoke of the doctor as the patient's physician, philosopher, and friend. Those qualities are needed more and more. We seek to be the patient's guide through the health and social care maze, which is a system which is a maze. The multiple tiers of government, bureaucracy, and disjointed, often unintelligible and incoherent policy tends to trip us up when we're just trying to do the best that we can for our patients. Policy settings are often out of date and they can defy logic. In partnership with community champions and experts, the successes are better achieved. I am eager to see the policy proposal recommended in this report taken up by all levels of government. This work has been done for policymakers and is ready to be put into policy improvements that will begin to stop the growing disparities in health that we are seeing within our otherwise wealthy, healthy country. Addressing the needs of vulnerable people in these settings and setting up the system to provide them for them strengthens and makes systems more robust for all. You will have heard and will hear further from other speakers today that opportunities for people to maintain good health and well-being are strongly affected by the resources, services and supports within the communities, environments in which these people live. That has been known for a long time. Health policy has increasingly recognised that there are priority population groups that need specific policy attention if they are to have health outcomes that are as good as those of the rest of the population. There is a growing awareness that those priority groups that generally live within communities that have higher levels of socioeconomic disadvantage than others. Priority groups commonly have fewer resources than others, and because of their resources, also commonly live with communities that offer fewer financial barriers to housing and other material needs. If it therefore seems remarkable, straightforward common sense that to improve, message coming up. It therefore seems remarkably straightforward common sense that to improve the health of people who are known to experience poorer health outcomes, who are known to be more likely to experience social disadvantage, we need to work not on them, but within the communities in which they live. We must address the barriers to good health and also within the community, within those communities. But straightforward common sense doesn't easily infuse policy making. I'm going to use my experience as a GP during the COVID pandemic emergency to reflect on what it took to get some common sense and expert advice and evidence taken up and implemented by multiple government agencies and initiatives to deliver actual, real-time, effective preventive care and care to vulnerable, hard-to-reach people. Those who are in Melbourne will not forget that we were the most locked-down city in the world. In my area, we were asked to run a Commonwealth GP respiratory clinic to test for COVID, provide care, and later on to provide vaccinations to the community. In the peak of the COVID-19 pandemic, it was discovered that our area had a high rate of infection and was indeed in greater need of testing services and to trace and test the cases. There was an agreement with the federal government and the state government to allow more testing at our site. There was then further collaboration with state governments to provide wraparound services to provide for people having to isolate and to provide health messaging to prevent spread within the community. Local schools use their teachers and students' skills in local languages to work with council to produce video and audio clips that could be understood by those who could not read or communicate in English. A state government community group was also set up to pick up the needs and concerns and mitigate these with clear, further, respectful messaging for various groups. When it came to providing vaccinations, the need in the area was deemed to be urgent and high risk. So the local government and the mayor advocated with state government and with local GPs we worked with, and we also worked with the federal government to provide vaccination sites and practices, the local badminton hall, and indeed the Whitten Oval, site of the Western Bulldogs AFL team, and aligned, as we know, to VU, whose magnificent netball and basketball halls we used. All levels of government working with community was an awesome outcome. The report that we are launching today, Getting Australia's Health on Track 2024, presents evidence-based and known to be effective policy improvements that will directly enable communities to create healthier environments. They have to want to do this to understand the need and not be out of pocket for doing so. That's why funding must be provided and must flow. It can also make preventive health initiatives more effective, but designing within the communities needs to meet the needs of different particular community groups. Our wrangle with COVID taught us that messages which can and can't work, and they vary community by community. But core messages are core. Also, what will improve access to the most appropriate care for people who face financial and practical barriers, and important is in doing so, making the case that a stitch in time saves 9. Probably most importantly, that what we can get is national, state, and local governments working together in a common sense approach to all the communities of Australia, so that you can stop the worst outcomes happening for people who shouldn't have them. The policy actions that are recommended by the Australian Health Policy Collaboration's experts were developed by investigating what makes it difficult for many communities in Australia to have the same good health and well-being within their populations as others do. Taking a systems approach to preventive healthcare is not new. Using it as a way of identifying what policy barriers cause problems and what can be done to change those and to create opportunities for better health instead is practical and grounded in the recognition that universal policies are not enough. This is from people who know in the system and work within the sector. It is clearly obvious that while they benefit many, they don't work well for many others. The report puts forward 4 policy objectives, 4 aims for policymakers that take forward the National Preventive Health Strategy ambitions that health equity be achieved for priority populations and that all Australians live in good health and well-being for as long as possible. Those might sound like motherhood statements, not real ambitions, but they're not. For those Australians who live in well-resourced communities and have adequate resources themselves, living in good health and well-being for as long as possible is now normal. People in these communities have stopped smoking, reduced all health harms that tobacco use brought into otherwise healthy lives. They have taken to heart and they've opened up their wallets to the public health messages that being physically active in this sedentary world of ours is very important, both for physical and mental health. They are knowledgeable about good nutrition and have ready access to fresh food and products. Some areas, like mine, are regarded as food deserts, and the accessible foods tend to be fast food, often drive-through, cheaper but not nutritious. Supporting investment and augmenting provision of better supply and facilities can be done by local government authorities, and it would pay dividends in better health for the population. Australia has a long history in bold health policy measures regarding tobacco smoking cessation. The current smoking rates are amongst the lowest in the world. In Victoria, there are strong public health requirements on food premises, all public premises, and on public spaces that smoking near these places is not allowed and often is in breach of legal provisions. That was a tough battle. It was a long campaign with many threads, but ultimately it led to successful, good policy, informed by good evidence and executed by buy-in from all sectors of the community. That is a public health overlay requiring all public policies to address a health priority. That is getting close to health in all policies and shows the value of a health and well-being overlay for all state and territory and local government planning provisions. Having to consider the health impacts of a local community and of more fast food outlets or more alcohol outlets, or of developing new communities without adequate access to fresh food outlets, walking zones, tree canopy cover, and green spaces will directly benefit health of communities. Not being able to appeal planning decisions that are based on health and well-being impacts will cement in the importance of the retail and commercial and built environments on the health and well-being of our communities. Ensuring that every local government authority has a clear role in improving the health and well-being of their communities makes common sense, doesn't it? In Victoria, we have become used to health and well-being of communities being one of the core roles and responsibilities of local governments. In my own local government area, Hobsons Bay, local council keeps track of the health status of our community. So we know that less than half of young people in our region say they can access mental health care services when they need it. We know that 54% of the community are meeting physical activity guidelines. And we know we have higher rates of some health conditions than the wider region. The Council has 4 priorities: to promote active living, to tackle climate change and its impact on health, to increase participation in the community, and to provide a safe and healthy, equitable society. We health professionals and services can see benefits for our patients when the community environment considers their health and well-being. Shouldn't every community have the benefit of local government engaging in that? The policy proposals that the forthcoming National Health Literacy Strategy should have a particular focus on the need of disadvantaged communities will help not just individuals, but also health services and professionals like myself. The health needs of communities of disadvantage are so great that spending time to explain basic health information for some who have limited understanding of what helps them to be healthy and how to be healthier is rather like robbing Peter to pay Paul, as the old saying goes. Supporting communities to learn about the ways to produce, prepare, cook, eat and store food safely, nutritious food and good value for money with improved food management skills is acknowledged as a useful intervention. Policy today, however, does not support this deployment. There is no funding model for such innovations. My own personal journey will attest to this. To spend time to do this is to provide the best healthcare and to someone who needs it, but it takes time from others. Others also need that time. It is also expensive time for me to provide that, and a financial barrier that expects all of us. Like language literacy, health literacy is a product of our environment and is fostered and grown by being part of a health literate community. Requiring primary health networks and local government networks to formally collaborate and publicly report on preventative health needs of their shared communities also makes sense. PHNs and LHNs both have the same responsibilities to provide and improve the healthcare and health outcomes of their communities. Changes suggested as far back as the 2008-9 report I mentioned earlier identified this. That has not changed. If a program or process works, they will be utilized because it works, not because participants are compelled to use it. And at a time when we know health services at both primary and acute levels are not keeping up with community needs very well, doesn't it make sense to require them to work together to improve health and well-being and prevent chronic diseases in their communities? The buck passing and cost shifting blame game benefits no one, and conjoint ownership of problems and solutions is better expenditure of the tax dollar and personal contributions and leads to better outcomes. Doing it separately or not at all does not make any sense. And finally, to equitable health access to health. Access to healthcare. Getting Australia's Health on Track 2024 proposes long-term flexible funding for coordinated care. The Minister made it clear he wants to see multidisciplinary healthcare and coordinated care. This is the proposal that is ready-made for government consideration and implementation. Reducing financial access to barriers to health people is what Medicare in its first iteration as Medibank has brought in. In those days, Australians could go bankrupt because of their health bills. That problem has been solved to some degree, but we have another. If people don't have access to bulk billing medical care, they're likely not to be able to pay a gap fee. When I started practice in Australia, having trained in the UK's NHS, I was blown away with our access to community-based services, particularly pathology, radiology, and non-GP services, medical and non-medical. This allowed me to look after patients in the community almost entirely, unless they had an emergency beckoning them to go to hospital. We had access, we had affordability, we could instigate, investigate, and intervene early. These components made the Australian healthcare system a standout in the world. Now, being referred for diagnostic services or allied health therapies may not be affordable. Access to GP services is dwindling as those in practice retire or reduce their hours, and less new graduates choose GP as a career. Our excellent service system is under threat. The cost of availability of transport to specialists or other services may be a complete barrier. It is clear that universal provision of healthcare is not sufficient to enable universal or equitable opportunities for good healthcare. We must do better, and getting Australia's Health Track up 2024 is an excellent set of proposals. To conclude, this report represents the best expert advice that can be provided to policymakers and others in government at all levels, and provides them with immediate guidance about what can and how this can be done. It is a resource for us health professionals to add proposals to our endeavours to see how we can grow from them. It is an important resource for service providers and administrators who want to see improvements. I encourage our policy leaders and makers to consider this report very carefully and to see it as a resource for decision making. I encourage health professionals to engage, think outside the box, and think how they can participate and enhance the system we all work in, improving access and outcomes for better care for our patients. I'm very pleased to launch Getting Australia's Health Track on Track 2024, and I wish this report and all those who put it together considerable success and in improving healthcare for all Australians. Thank you very much.
Thank you, Dr. Honourable. We're very pleased to have had you talk to us today, particularly as you can talk from such a deep well of experience and length of experience about the issues that this report is going to help address, we hope. Here I go again. Let me now introduce the expert panel who led the work. Dr. Erin Laylor, AM, CEO of the Alcohol and Drug Foundation, was chair of the Microsystem Working Group. Tracy Johnson, CEO of Inala Primary Care in Queensland, was chair of the Mesosystem Working Group. And Professor Tim Gill, the director of the Obesity Collective and a long-term research leader in the area of preventive health, led the Macrosystem Working Group. Each of these will now talk to us about the work that was undertaken, the problems identified, and why these policy objectives and policy proposals are the most appropriate to implement now. Erin, no, I'm going to tell Tim Gill first. I do apologise. Tim.
Thanks, Rosemary. You will notice from, first of all, I'd like to acknowledge I'm on the lands of the Gungungara people and pay respects to their elders past, present and emerging. So you'll notice from Rosemary and Makesh's presentation that we've chosen to examine the issues and potential solutions in this report from a whole of systems perspective. And we chose this approach not to serve some academic or ideological purpose, but because we recognise to effectively address health inequalities within disadvantaged communities, this will require joined up action of multiple sectors and agencies, which is also tailored to the specific needs of these diverse communities. So the socio-ecological model, which you can see on the screen at the moment of health here, illustrates this concept nicely, although there's probably more sophisticated models that highlight the complexity of system level action. This simply and clearly visualizes the multiple layers and levels of societal factors that influences an individual's or community's behaviours and health. And in doing so, it highlights the importance of the need for action across each of these layers to ensure actions to address chronic disease in Australia have the greatest chance of success. So whilst most people accept action at the lower sort of levels, the rationale for action at the macro or higher policy and regulation level often confuses people because they may not by themselves directly impact upon health, but they are essential to enable and reinforce programs and projects initiated at those lower meso and local levels. And more importantly, they also help to remove some of the social and structural barriers that prevent disadvantaged communities from gaining the same benefits from well-designed health promotion programs and projects. So if you want to address difficult societal problems such as chronic disease, it's not possible just to act at one level of the system. You must have multi-level action and there must be connectivity between actions across the multiple levels. So if we move on to our policy recommendations, you can see that policy objective 2 focuses on actions to achieve healthier environments through appropriate use of planning, regulation and legislation, and seeks to achieve that function of connectivity by focusing on the powers and responsibilities of local government. And local government, as we're all aware, is the tier that's closest to the community and thus best able to respond to the specific needs that they need for a healthier life. But they need the legislative support and funding of state and federal governments to take this task on in a consistent manner. And so the development of local health and wellbeing plans, as recommended in Policy Objective 2 here, will enable and encourage LGAs to build on existing services aimed at creating the best environments for promoting health, but also at the same time responding to the specific needs of the communities they serve. And in doing so, we believe this will help reduce rather than exacerbate prevailing inequalities, as Stella pointed out. There are good examples where this approach has been effective at addressing specific issues such as sustainability, transport, recreation, but it needs a broader application within the health perspective. We all now recognise that health and wellbeing are influenced by so many factors that are outside the health domain. And as such, much of the regulation and legislation introduced by state and territory governments has enormous potential to impact on community wellbeing. Yet rarely are these regulations and legislations assessed in terms of their impact on health. In addition to the direct impacts that these regulations may have, these regulations also define the framework in which local governments operate and make planning determinants of their own that impact on the wellbeing of the communities. And the absence of a health lens in this situation to planning decisions means that local environments may become less supportive of health and wellbeing and contribute to widening health inequalities in disadvantaged communities, as we see when other considerations drive planning decisions around issues such as the number and siting of fast food, tobacco and alcohol outlets. The need to create local environments that support and enable healthful behaviour is also essential in improving health literacy that Mukesh talked about. So health literacy is one of the focuses of Policy Objective 3, which addresses initiatives tailored to disadvantaged communities. So health literacy is the capacity for people to access, understand and act upon health information in ways that benefit their health. And we know that disadvantaged communities often have poorer health literacy, which is associated with worse health outcomes. So unfortunately, actions to improve health literacy often are restricted to a focus on individual skills and understanding, instead of addressing some of the other key influences, such as the services available and the access to those services, especially in rural remote areas, as well as the development and provision of say, culturally appropriate information and programs and services tailored to the specific needs of the community. And in addition, we also need to consider the environmental changes that are going to make it easier rather than harder for people to act on any learnings gained. So I'll now hand over to Tracy, who will take on some of the other initiatives within our policy objectives.
Thanks, Tim. Lovely to see everyone, and I join you from the lands of the Yagara and Turrbal people in Brisbane's west. The group that I had the privilege of chairing was the Meso System group, and one of the things that we agreed on fervently, and the Minister spoke to it earlier, he talked about a health system. We in fact agreed that what we have is a sickness system. We have a siloed group of individual players, whether they be hospitals or primary health networks or primary care players. And what we're funded for is activity where people are already unwell. We do far too little around planning for how we can make them well for longer, how we can address deficits in their behaviours that they might be carrying with them because of their poverty and circumstance. And most importantly, what we agreed on is at the moment there are no incentives formalised and written into the agreements that we have with our LHNs and PHNs to formalise their collaboration around needs assessment, around collaborative planning, and most importantly, investment in preventative health as opposed to investment in building more hospitals and delivering more services for those who are already sick. So there was a very strong call for creating that common objective and planning framework so that we in fact end up with a health system rather than a sickness activity-based funding model. We then moved fairly quickly into the need for team-based care. The Minister spoke to that. He mentioned things like social prescribing as well, because the sorts of models of care that we've had in existence for so long have often been very medical and have not allowed people to access the full range of supports that they need. In an environment where we've got workforce shortages everywhere, but particularly in low-income areas and rural areas, we in fact need to be thinking about who is it that can do this care? What is their scope of practice? How do we fund them to work together? And how do we ensure that they get access to the whole team to deliver comprehensive care? We're not doing this thinking in an environment that's a vacuum. At the moment, there are a number of reports that government has commissioned that we're speaking into. One of those reports talks about having a ratio of, for every GP in general practice, having an equivalent non-GP clinician available to support the needs of the patients in that practice. This was highly endorsed and supported by the group that I chaired. In addition, elements around implementing a social prescribing model and working with our mental health sector differently were also heavily endorsed. The third thing that our group looked at was looking at ourselves, and I apologise for the noise that's coming through in this building at this moment. As a community of healthcare providers, too often we in fact are the problem and the barrier. So making it attractive for healthcare providers to work in low SES communities like the one we serve, which is a social housing area in Brisbane's West, or in rural areas, or in areas where you might be dealing with patients who are particularly vulnerable. Too often we look at those patients and go, isn't it nice that somebody else is prepared to do this work, even though we've been trained to do it? So we need different incentives to attract and retain workforce. And we also need to educate our young people coming through our education system that most of their work when they're working in the healthcare system will in fact be with those who are older, those who are sicker, and those who might have less means than they do. The final area that we looked at was, what are the financial barriers that are real? I'd like to pay compliment to another Queenslander, Sandy Gillies, who's the CEO of the Western Queensland Primary Health Network. She really critiqued the notion that there's market failure in health. What she said was that in fact there are no markets in many areas because the financial incentives create such access barriers. To give you an example from my own recent experience in the last few days, we work in Queensland's largest social housing community. It's highly multicultural. We have the biggest burden of mental health issues in all of Queensland and the highest rate of disability pensioners. Despite that, last year, in this region, 37,000 consultations occurred across psychology, psychiatry, general practice, and other service providers in the mental health space. We're currently planning to launch a practice in a nearby suburb. It's just 20 minutes away. Despite our suburb having a 35% higher population, that nearby suburb delivered 40,000 mental health consultations for a group who are far more affluent. What this tells me is that our provider network is driven by money. It is driven by easier work. It is driven by the incentives that we need to get right so that in fact when people have illness, they have access. And at the moment, that was strongly spoken to in our group as not always occurring. So I'd implore you to think more broadly than just about money, but also thinking about service provision and preventative health in creative ways. Thank you. I'd now like to introduce my colleague, Erin, and the work that her group did. Over to you, Erin.
Thanks, Tracy. And I'd like to start by acknowledging traditional owners of the lands that I'm presenting from, and Honourable people, and pay my respects to elders past and present. And as you've all heard, the microsystem group, which I had the privilege of chairing, was considering the context and roles of local communities in addressing inequity. And much of the discussion we had centred around place-based approaches. So we know that place-based approaches have been a core part of strategies to improve community wellbeing for many years, but paradoxically, as Rosemary noted, we find that if it's not done right, they can lead to inequity. And governments, philanthropic organisations and others have been investing in place-based approaches to address disadvantage. And we see many teams delivering programs within a single community. And as an example of this, some of the communities that my organisation, the Alcohol and Drug Foundation, works in, have about 16 different teams working on adjacent issues such as alcohol and drugs, homelessness, suicide prevention, adolescent wellbeing, youth justice, entrenched disadvantage, etc., with very little operating to join those efforts up. So the group discussed the challenges that communities face in delivering place-based approaches, and these include fragmentation, such as that which I've just described, difficulty accessing and using local data, challenges in evaluation, and finding ways to ensure that there are enough people and capacity in the community to support sustainable efforts. So we talked about what solutions might look like and how community efforts in addressing place-based needs can be supported by attention to also strengthening the system that they operate within, as Tim's outlined. Now, you've heard that our proposed solutions were workshopped over many sessions with iterations alongside the proposals from the other working groups to deliver what we see here today. And what we identified as solutions operating at that microsystem level need to consider our workforce, both paid and volunteer, better access to data and mechanisms that support coordination using systems thinking approaches and that support local communities to do rather than be done to. And one of them, in fact, the overarching one, is a national framework as outlined in Policy Proposal 1, which aims to address many of the challenges that we identified and that are readily recognisable by many of the people who are here today who work in delivering place-based approaches. The national framework would provide an overarching structure to guide the development, implementation and evaluation of place-based programs, would provide support for local collaboration and community-led solutions, coordination of the many funding streams and services, and coordination of local efforts at a system level. And this framework could also include resources that support information sharing and systems thinking in delivering place-based approaches. But we also recognise that a national framework wouldn't be enough, and that we know that addressing disadvantage and social issues that contribute to poor health outcomes does take time. And community organisations working to strengthen community wellbeing need time to engage with their community, identify local needs, and understand the best way to address those needs. We also know that evaluation of these sorts of approaches takes time, and that means that funding to community organisation needs to provide flexibility for programs and initiatives to be co-designed and implemented with the community, focusing on addressing community needs and measuring outcomes. And the third policy proposal that we identified really recognises the importance of the workforce at a local level. Community development workforce with skills in engaging community, accessing and interpreting local data, evaluating, co-designing and building strong partnerships at a local level is really critical, as is the volunteer workforce that sits alongside them. And so the group identified the importance of strengthening this workforce alongside the workforce that Tracy's referred to and support for community organisations to build their volunteer base. So if we move to the next slide, just to bring it all together, as Tim has pointed out, none of these policy options exist in isolation. They're all connected. We've spoken about the socio-ecological model of health and policy options identified in getting Australia's health on track that stretch from the policy context to the community, to the organisations within community, to the organisations that influence community and to the people that live there. But we need action on them all if we're going to address the inequity in health outcomes that were identified in Australia's Health Tracker report that Stella spoke to. And I'll hand back to you now, Rose.
Thanks, Erin. Sorry, I was a bit slow getting my microphone off. I'm going to ask Dr. Therese Riley of Victoria University, who leads complex community interventions in local communities nearby the university, and Rosemary Hancock, who's the Manager of Social Policy at the Municipal Association of Victoria, to just briefly talk to us about what it's like on the ground, how it works from the perspective of local government where there are mandatory health and wellbeing plans, and what it's like to try and work in a community of complex needs with complex interventions. Can I ask Therese to speak first?
Thank you, Rosemary. And I would also just like to acknowledge that today my feet are on the land of the Burrawong people, and pay my respects to elders past and present. And so I guess I've got an opportunity just to share some initial thoughts from the presentations today, and also being a part of one of the working groups. And I'd say, firstly, we've certainly come a long way from a time when we would develop programs and initiatives outside of community context and helicopter them in and then wonder why they don't work. And in the field of complex intervention research, which is, I guess, the kind of field that my research is positioned, we now understand that place-based community interventions are complex social processes. So people's health is embedded in a community ecosystem that's made up of not only organisations and service infrastructures, but communities that have histories, that have resources, they have networks, they have narratives. And that makes up the nature of the kind of community ecology for which people live, work and play, as we say. And knowledge of the complexity of community life is now understood to be critical to the work of program and intervention design, implementation and evaluation, a little bit that Erin just spoke about. So as a result of needing to better understand the complexity of community life, a big part of that is, what do we do and how do we gather the knowledge about the dynamics of communities that we need in order to be able to make sure that our efforts and our programs and our work at a community level actually sticks and delivers the kind of population outcomes that we hope to achieve. The focus, I would say, on that kind of complexity of community life and acknowledging that that's a really important critical component, certainly of research in the field and inevitably in terms of practice. What it's meant is that it has elevated the importance of lived experience and the experiential knowledge of practitioners who are at the front line of our prevention and health efforts. And a part of that task has been to bring together differing forms of knowledge and perspectives at a community level in terms of the kinds of collaborative structures that we bring together. And collaboration, of course, has been an important part of health promotion and prevention from way back to the Ottawa Charter, and still an important component of the work that we do at a community level. However, today, certainly from a research perspective, there is a big focus on what is the nature of our multi-sectoral configurations when we bring different sectors together. How do we begin to pay attention to system level or community level impacts in addition to the effects on individuals? And importantly, from a community perspective, how do we ensure that our collaborations embrace an empowerment agenda when we're bringing community members around the table? So current research has and continues to focus on the understandings of collaborative practices. So how do we go about this work? And it builds on an increasing relational infrastructure being built at a community level and then up through other systems to our regional and state level, that's able to harness the existing knowledge and resources of communities and community members to strengthen that community capacity in order to deliver on those community outcomes. So the policy recommendations that have been presented to you today definitely go some way to creating that enabling environment where both health and community literacy coalesce. We need the health literacy of community members and the community literacy of a health and other workforces, and that can exist within and across that workforce so that community outcomes are not only a possibility but also a likelihood into the future. So I might pass on now to Rosemary Hancock to talk a little bit about local government.
Thanks very much. And look, great to be here. I'm coming from Wurundjeri country in Melbourne. So look, as we speak, executives in the 79 councils in Victoria are preparing their incoming briefings for the over 600 new councillors who were elected last weekend. And in this work, health and wellbeing will be included in the plans and initiatives that they'll need to develop and commit funds to over their next 4-year term. And this is because it is mandated through the Victorian Public Health and Wellbeing Act, where health and wellbeing has to be consciously factored into every council's major plan for their community and their annual budgets. And as you know, councils have many touch points impacting local health and wellbeing, parks and gardens, local services, funding for sport and recreation, blue-green infrastructure, so many things, as well as their community services. And as Dr. Hackwell has illustrated today about the work undertaken by his council at Hobsons Bay, interrogation of local health data will be undertaken. It's quite a formal process, and local communities will be consulted on their health and wellbeing priorities early on in the new council term. And having statutory responsibilities in place also provides opportunities for that connection with the state government. Bringing councils together so they learn from each other, it saves time and really helps those councils with fewer resources. Of course, there's great disparity across the state, from small rural councils to really large, complex metropolitan councils. And this is particularly relevant in the context of addressing inequities across the state, which is one of the issues arising in the discussion today. And I'll give you local government's always very practical. So I'll just cite a couple of very practical examples where having statutory roles of local government really contributes to health and wellbeing. Because councils do have to reflect the priorities of the state health and wellbeing plan, tobacco control is a major priority in that. And as a result of that, most councils in Victoria are participating in very extensive local government tobacco control program where they are visiting tobacco retailers across the state. And because of that state-local interaction, for example, with the rapid rise of e-cigarette retailers, around the time of the pandemic, councils actually was telling the Department of Health they were seeing these places emerge and selling products, and inevitably that generated consideration of the regulatory environment at the time, which in turn has influenced national strategies and things like that. The other one where it's really great to see the initiatives being outlined here is in how health and wellbeing can be used better in the planning system. And I'll give you a couple of examples. Certainly, councils, through the planning permits that they issue for certain activities, would love to have a bit more backup at times in terms of where certain places are located, such as tobacco outlets, alcohol outlets, and fast food and all of those things. The other area that I'll also give you a quick insight to is that how statutory roles can really help the work of local government is, just a few weeks ago, we had over 300 town planners on the line, all thinking about gender equality and how that might impact or should be considered in the municipal statements guiding council's planning policies for towns and cities. And yes, that would be done also, but having that statutory role means that it's done in quite a formal way. There's a process in place and it's done systemically, and that's sort of been a real advantage. So that's very quickly some brief insights at the practical level. I'll hand back to you, Rosemary.
Thank you. It's unusual for Rosemary's to hand to each other. We've got a panel session now, and whilst we've had some of the time taken up with the discussion and presentations thus far, I don't think anybody's going to mind that, because the information that will be now on the permanent video record that will be on our website, it's going to be a very rich resource, and it will answer some of the questions we've already received. Let me remind you that if you wish to post a question, please do so in the Q&A box on the base of your screen. The number of questions we have go to, I think, two issues that I will ask the panel to comment on. And you can see that our three chairpersons and Dr. Harkwell are the panel. The two issues are, it could take government a long time to do anything. What can we do in the meantime to increase what happens in the local communities, to increase collaboration? Do you have any tips for how to do that? And the other is, how do we better work across policy silos? How do we work with what we've got better than we're doing? Can I invite somebody from the panel to lead off in, if we have to wait for government to not do what we're recommending, what else can be done by people at the local level?
I might kick in as a person at the local level. So we see patients, we see data, we see lives affected by this sort of thing all day, every day. And one of the things I like to remind my team, and indeed people we meet with, are that we are the system. Too often I hear people going, if only the funder, or if only the system, or if only the hospital. Well, actually, we're all part of this system. And if we all gave a little bit and participated in some of the place-based co-design work that one of our colleagues has just spoken about, we can make a difference. And certainly my team, we're a normal general practice. We get our funding from Medicare. Medicare is not a generous payer. But at the end of the day, when we're looking at the lives of the patients that we serve, unless we do the sorts of things that Mukesh and myself and our teams have done for many years, which is get out from behind our desks, attend meetings, engage with our PHN, because it's surprising how often they can seed fund little projects. We've certainly benefited from that. And then likewise, looking at our data and loving our data. A lot of general practices are not very good at looking at their data and loving their data. We can produce business cases that I've certainly taken on behalf of our team to Queensland Health and other funders, and they've funded initiatives. So sometimes it's got to start with us and what we know on the ground, the ideas that we might want to progress, and the partnerships that we think we can put in place so that we can share our resources and do this better.
Thanks, Tracy. Any others?
I'm happy to chip in, Rosemary, and I agree that I think there is a lot that can be done. And in fact, all the policy proposals in the report launched today really go to the fact that we need action at different levels of the system. Government alone can't do it, communities alone can't do it. But when I was talking to the policy proposals that the microsystem group came up with, we identified that there are often many groups working within a single community, all delivering initiatives to improve the wellbeing of that community and address disadvantage. And often there's visibility of each other group because there's cross membership, but there's no bringing them together. And I think just a conversation about what's happening within a community across the different groups happening from time to time to increase visibility of what's going on and how those initiatives delivered by one group might add value or be used by another group would be a really constructive way to start to see change happening from a place-based approaches perspective. But I don't think we should ever use that as an excuse. Like, government will take time, but I don't think we should just, it has to happen at every level. So we've still got to be working at trying to influence the decisions that government makes. To Tracy's point, speaking out, representing community, gathering information about the impact, the needs, the opportunities for change, the results that we're seeing from the efforts that we make at a community are all things that help push the bar a little bit further along in terms of achieving the sort of change that we need to see.
I'd just like to reinforce that from a policy perspective, because I know a lot of people say, oh, it'd just be so much easier if government would just make the right policies and everything would be solved. But as Erin and Tracy have said, all the other levels have to be in place as well. We all have to be working towards, achieving that multi-level action. And sometimes governments do take a leadership role, but more often than not, they have to be forced into, making the right sort of decisions and action. So, if we're not prepared to keep working with communities, keep pushing, keep putting things on the agenda, then we're never going to pull governments into making the right sort of decisions.
Mukesh.
Yeah, thank you. Look, necessity is the mother of all invention, and we saw that big time during the pandemic. I hate to bang on about Victoria because we did it pretty tough down here. but it actually gave us the opportunity to do things differently. Our engagement directly with state government, with general practice primary care, increased dramatically and continues to do that. We've even seen the Treasurer of Victoria put money into health and try and support general practice do things slightly differently in a trial methodology. What pump priming allows, and that's what COVID did, was we actually saw state government in this state providing money to help more areas and more sites and more people do vaccinations so they can get the numbers through. That would never have happened before because of various cost shifting and blaming. And I think we've got to learn from that and not bury it. And there are people who can take out the cudgels and make those things happen. And yes, it's about getting to the right people who can make decisions. I remember walking into the Premier's office with my phone on, speaking to someone, only very rude, but nonetheless I had to finish off my conversation with Commonwealth, trying to get some more funds to do what he wanted me to do and go to the press conference with. So it makes that sort of difference if you can actually give a real set of parameters that they can work for. And this is what these documents do. They give good ways forward. There's policy evidence based. So it shouldn't be quite so much a shot in the dark, but grabbing onto something that may well work.
Thank you all. And can I just let people know that in the chat section of the webinar, not the Q&A section, we have the links to the 2 documents that are being talked about today. And that will, for the last question that we've got at the moment, also provide you with the access to the VU website, the AHPC website on Victoria University website, that will eventually hold the video of this discussion and the transcript. It will take us a little while to get them both there, but they will be there as soon as possible. Can I put one more question to you from the questions we've received? And that is a question that says, one effective way is to encourage governments to enshrine these issues in legislation. And Wales is quoted. Wales has established a Wellbeing for Future Generations Act, which requires health and wellbeing in all policies. As many of us know, there's been a long-held hope, in fact, aspiration of the World Health Organization that health would be enshrined in all policies. The question is, do we think Australia will ever do this? And if so, how do we get there? Your thoughts, please.
So I think we will get there. Whether we get there in a timely way is altogether different. But I do think if we look at what Jim Chalmers has done as Treasurer, he's broadened the reporting card for government to include a whole bunch of other measures other than just is the budget balanced and how many people do we have on unemployment lists. So I think this is a first and significant move by government to recognise that there are a variety of indices that we need to be tracking as a society to say, have we got the society that we want or not? I think if we look at Wales, if we look at the UK, where they have a Health and Social Care Act, where they are deliberately looking to bring together different sectors of government, not just different parts of the health sector. They're producing staggering results because in many of our communities, it's not a shortage of resources, it's a shortage of the coordination of those resources and a desire of those resources to understand how they can work together. So the more we do this place-based work, and it is an emerging theme and a movement in this country, I suspect in the nearer term, we will start seeing that embraced by policy. Certainly government has already done some things through Prime Minister and Cabinet to bring the health and social care sector together. So my expectations are high, even if my experience is somewhat lacking.
As a former chair of the Australian Institute of Health and Welfare and with my former board member, Erin, we were seeing a big trend to social policy and health policy coming together with the understanding that the more you did in the social side, you could actually improve health and vice versa. I think taking it to the next level became very difficult when it was fighting for its life as an organisation. But now that it's back on its feet, I can see a lot more chance of a very highly respected and safe place for people to share their data from states and territories and departments, and then to be able to provide other sorts of reporting will give good policy direction. Then you've got to take it to how do you go to a 3-year funding cycle? How do you go to an election cycle federally? And how do you do things in the state that aligns? And that's why, you know, these things do take time. But the core drive has to be making, and I think I've seen it somewhere in somebody's note in the chat somewhere, you know, it is really feeling the pain points. What is the desire? How can you fulfill what you need by making it something you can't escape from, making it a change that has to be, not that just would be nice, but is vital.
Can I also add that many of those initiatives that you see in reports such as the Welsh one were actually born in Australia. We've been thought leaders in this area for a long, long time, just haven't been able to get consistent action around this issue. That's not to say it hasn't been tried. I mean, certainly South Australia did bring in a focus around, you know, health in every policy. New South Wales Health had the Premier's priority action on childhood obesity, where every department had to provide impact assessments on their policies on childhood obesity. There just hasn't been the consistency or retention of these ideas. And in some ways, I think the other thing we need to do, apart from educating policymakers, is also changing some of the social norms. We've got to get society to start thinking about health and well-being as one of their primary assets that they should be protecting at all costs, and should be demanding that their politicians work to protect.
Thank you, Tim. I think that's an excellent summary of the main points of today. And as we're now out of time, I do apologise, we're slightly over time. I want to wind this up by firstly thanking all our speakers, from the Minister, the Vice-Chancellor, through our panellists, and Mukesh particularly for being the keynote speaker. It's a really important piece of work. There's been a huge amount of effort go into this, and a decade long in the work towards it. But what we've produced is not just a set of good ideas. What you have available to you now are those 2 reports and their predecessor reports for you to use as your resources, whether you're a bureaucrat, a health provider, a local government authority member. These are your resources. If we want to see change, we have to advocate for it. We have to lead it. We have to influence it. We have to role model it. And what you have in these documents is material that's straightforward, simple, giving you the best evidence possible and the best guidance possible about what could be done from your patch of the world to achieve some of these changes. We want to keep working on this. We want to keep working with you. Please stay in touch. Thank you for joining us today and for making this what we feel is a very successful webinar. We look forward to working with you into the future. Enjoy the rest of your afternoon. Bye for now.